today. My name is Jessie Sullivan, and I'm the Medical Director for the Center for Regional Healthcare Innovation at the Westchester Medical Center. And the Center for Regional Healthcare Innovation is a new organization founded by the Medical Center for the what we're going to do is the DSRIP project, and I hope we'll be around some other interesting things as well. But right now we've got hands full with DSRIP. And I'm joined by, I don't know if you just want to introduce yourself and your voice.
This is Brenda Pollock from Manette. My name looks like Kira Wallace on the screen because I'm using my colleague's account to host this webinar, but I'm working with the center, and I'll be kind of facilitating tech in the background on the webinar.
Right. So we're expecting about 18, 19 people, so we thought we would try to leave all the lines open because I would really love it if people ask questions. I want to remind everyone, so please don't put us on hold, and feel free to ask questions as we go. And if we have a problem with background noise, Brett can try and mute a line, or if we get a big problem, we'll have to mute everyone. But and then Brenda and Lauren, please keep honest if we start getting the questions and get sidetracked. Just whip me so we keep moving along. But I would welcome people to interrupt as we go. But I just think we probably won't. We won't probably go on for introductions because I can't see who's on the call. But do ask a question. Just kind of speak up and let us know who you are. So can you move us to the first slide? So last week I was in Washington, as maybe some of you heard me say. I got snowed into Washington, and I didn't. I did not have a meeting with Secretary Burwell, but I did. I was at an AMA meeting, and CMS administrator was speaking, and he talked about this announcement that Secretary Burwell made on January 27th about how CMS is moving to value-based payments for Medicare. That goal is to have 30% of all Medicare payments be value-based payments by the end of 2016 and 50% by the end of 2018. And so that's a pretty big shift away from fee-for-service and towards paying for service in a different kind of way. And that made sense to me that he was talking about that because, and if you can go to the next slide, the week before, the New York State had released a document we were waiting for, which was the roadmap to value-based payments for the DSRIP project. And I've stolen just this one slide from the New York State's website and the links there if you want to go look at the whole deck. Payment form and as it relates to DSRIP. And by the year of the DSRIP project, all managed care companies doing Medicaid in New York must employ some payment system other than fee-for-service for 90% of their payments to providers. So that's by the end of 2018. So that's a pretty aggressive change in terms of changing how people will get paid. And the reason I thought that was kind of important is that as we get, and the reason I wanted to start with this, is that get deeper into DEC, you'll see that there are a lot of things that DSRIP is going to ask primary care to do. And as I was preparing the slide deck, I was thinking, oh, anyone want to do all this? I think the answer is that are two reasons, and one that I know is I really do know that primary care doctors care about their patients
Okay.
If there are things that will make for patients, that does matter, and people do care about that. So that is one reason. But there's another reason, which is that all things are paid for is changing. Medicare is changing, Medicaid is changing, and while there's no mandate, the commercial payers will change. They're going to follow suit, and they already are starting to do so. And fee-for-service is not going to be the bulk of reimbursement, and I think DSRIP is a way to get a little bit of help to get ready for the kinds of things that really we're all going to have to do anyway. So I just thought that was kind of a good context setting for how DSRIP fits in, or how the value payment is really something to think about. So next slide, please. So welcome and introductions, and I just did a little brief recap of payment reform. I know that some of you, and I apologize ahead of time, I'm sure some of you have heard this a lot, and you'll just have to cap yours for the first 6 slides. But I thought that some people have probably not heard so much about DSRIP, so we're going to just recap that briefly. Talk about our PPS and the timeline. We're going to go with a little bit of depth into DSRIP. The projects are very complex. We're not going to go into all of them, but we'll go into some depth for a couple. Talk about the role of primary care, and we're going to talk about what the next steps are, and we hope to hear from you all. And I think I'll just pause there before I go on, just to see if there's any questions at that point. Oh, next slide. So DSRIP. I stole this slide from the state's website. DSRIP is the Delivery System Reform Incentive Payment, sometimes this program. It's an incentive payment model that rewards performance and improving care for low-income patients, specifically for Medicaid. It's funded federally through Medicaid waivers. Next slide. Been 7 DSRIP programs throughout the country. I believe Texas was first, and then California. This program began in 2010, and as CMS has done more of the programs, they have become more prescriptive. So early programs were a little bit looser. It was more payment for hospitals, and the hospital had to have some quality projects, but exactly what they had to do to get that money a little bit up to the hospitals. And as the programs evolved, they become much more prescriptive, and the New York program has a lot of very specific things that we have to do. Next slide. So the context in New York is that, as many of you were in 2011, Governor Cuomo created the Medicaid redesign team, and the purpose was to have a blueprint for lowering Medicaid spending by $2.2 billion in the first year, and to develop a comprehensive plan for reforming the Medicaid program in New York. And they did implement that program. And 2 big parts of that program were moving Medicaid fee-for-service patients to managed care. So there are going to be a few to no Medicaid beneficiaries still getting services outside of managed care, and to create patient-centered medical homes and health homes, which we'll talk about a little bit more later. Next slide. So the state slide taken from their website of how they believe that the MRT program has bent the cost curve and saved $17 billion in Medicaid spending. The next slide. And so that's where the DSRIP waiver comes in. So New York, the CF has these projects to do DSRIP waivers around the country to help make Medicaid more efficient. And in New York State, we said, no, hey, we did this program, we saved $17 billion. We want some of that money to come back to be invested in improving the delivery system for Medicaid in New York State. And the state did get an $8 billion waiver, $8 billion to come back to the state to do projects. But it said a little bit prescriptive, like how that had to happen. The federal had a lot to say with it. So hospitals had to form alliances with other providers in the area and form what's called a performing provider system, a PPS. And, all you know that over the last summer there were many PPSs, trying to sign folks up to participate with them and form these coalitions, and are one of those coalitions, one of the PPSs. So next slide. So that's kind of, so let me pause there because that's kind of my little bit on the background of DSRIP. Okay. So this is where we are. So next slide. This is timeline. So starting last summer, we met at the Center for Regional Healthcare Innovation, and we went out and met with many of you and signed people to join our network and be part of our PPS. We did a very rigorous community needs assessment looking at the 8 communities in the Hudson Valley. And based on the community needs assessment, we picked our DSRIP projects from the list of projects available. We looked at where the providers in our network were located to identify some hubs where we would concentrate the work that we do. We had many work group meetings of big little ones to discuss how we would implement the projects. We submitted an application in December of 2014. We actually got the highest score in the state on our written project. So we thanks to all of you, we wrote a very good project. And we are about to submit our implementation plan, and DSRIP will begin in April of this year, so just around the corner when we plan to find out what our evaluation is and be able to start the project. Next slide. So these are the 11 projects that we picked, and one has highlighted in green the role of the project just particularly focus on the primary care focus for each of these projects. So that's what is creating a delivery system with advanced primary care at its center, and that means doing patients' medical home, meaningful use, including the referral loop, medication reconciliation, a lot of the things that medical hood, the things that will make communicating within the system for the sake of better patient care more effective. We're doing a health home at risk program, which means that we need to put some management support to primary care offices to help coordinate chronic conditions. A medical village project that involves creating some new FQHCs at a couple of where hospital beds are closing. We're doing a care transitions program to prevent readmissions. So this is linking discharged patients to primary care. We're doing a project on patient activation, which is going to be partly out in the community and partly at primary care sites that serve the insured, using a tool called the Patient Activation Measure to improve patient activation. We're doing integration of primary care and behavioral health, doing implementation of disease management, implementation of evidence-based asthma management, we're promoting smoking cessation, and improving cancer screening. So there are our 11 projects. Next slide. It shows that, so for each project, and we'll get into it a little bit in the next, that each project comes with its own list of detailed requirements. But there's some elements that cut across many of the projects. So for many of the projects, we need to have protocols and evidence-based care. Obviously, we need to have contracts with providers, and we need to DAs and BAAs to exchange information. We need to have electronic health records and to do health information exchange through the RIOs. We need to set up health homes to do care management linked to primary care. We need a better job of care coordination. We need to do performance reporting for the DSRIP required, and also for the measures that we decide among ourselves. We need to deliver on better care, and we need to do all of it in a culturally competent way. Next slide. Let's just again, before I dive into this project, and see if there's any questions. So we have 11 projects, and each project has a whole bunch of requirements, but we are not going to, I'm not going to talk to you about all 11 projects because we would be here very late. But I'm going to talk about a couple of them. So the most classic one is creating an integrated delivery system. And has a dozen to 15 specific requirements, and Lauren has put two of them here, two of the big ones. So one requirement is that all SANET providers in the PPS have to be linked to their local RIO through the need to do health information exchange. So find out the patient's been discharged from the hospital, be able to send the referral to a specialist that you have an arrangement with. So we need to make sure that can happen throughout our PPS. And all primary care practices need to achieve Level 3 2014 patient-centered medical home standards by the end of the third year of the project. This particular project of an activated patient is, my screen has just gone down. An activated patient is a patient who signed a RIO consent form. So we need to encourage everyone in their office to make sure that when patients come in, you have them sign a consent form so your patient's information can be shared across the RIO. And to the left is a list of the providers and practitioners who are part of the Westchester Medical Center PPS, enumerated here, and these are the parts that we need to have participate in this project. Next. So take just two projects and go into a little bit more excruciating detail. It has three kinds of requirements that we have to do. One is called Domain 1 requirements, and those are the basic infrastructure things that we have to do to meet. We've met the goals, and we have to. So, for example, in asthma, we have to implement evidence-based guidelines. We have to have all practices have a clinical interoperability system, and I think that what that means is the ability to share information between a primary care and a specialist. We have adhere to national guidelines for asthma management. We need to have agreements with asthma educators. We need to connect people to the SHINY. We need to look into the possibility of expanding care through telemedicine. To talk to Medicaid managed care plans about the benefits and coordinate care with them. And training for primary care providers in asthma education. Next slide. We have to do all of those things. On the hand side of the slide in blue are the same things I just read to you, which I will not read to you again. And on the left-hand side are the and numbers of practitioners that we have to engage in this particular project. And so we need to think about, for each of the types of practitioners listed on the left, how they do the things listed on the right. So for primary care practices, it's pretty clear that all 124 primary care docs and practitioners who participate in this project probably to do just about everything on the right. They need to follow asthma management guidelines and connect to the real. But for a PCP practitioner, for a gynecologist, for example, you know, a gynecologist isn't going to implement asthma guidelines. So what they do to help support this project, and they might, for example, promote to pregnant patients of children and to prevent asthma from secondhand smoke. So for each of these deliverables, we have to think about what mean for the kind of providers on the left and who has to do the things on the right. Next slide. So that kind of the metrics we have to deliver. We have to tick those boxes for each kind of provider. Then for each project, we have to engage patients in the project, and the state calls that activated patients. So for each project, we have to have meet a certain number of activated patients over the course of the project. And for asthma, it's the number of patients with an asthma action plan, and to have 500 of those by June 15th. Now, I'm quite confident that among all of you, we have, you know, among your patients, there are already 500 patients with an asthma action plan. But, of course, at this point, because you have an asthma action plan in your chart, doesn't mean that the PPS knows that we have 500 asthma action plans. So the very first thing we have to do between April and the end of June is to figure out how we're going to get from you the numbers of people who've met this requirement, and we need to figure out what kind of resources you need from us to make that be something that's doable and not too onerous. So that's the second kind of reporting we have to do. The first kind was those boxes we have to tick, the structural things. This is the activated patients, and you can see the number that we have to reach goes up each year. And then the third kind of measures that we have to do are more traditional performance measures. We have to ensure that the patients who are attributed to us are compliant with the asthma medication ratio, which is a HEDIS measure. The PKIs and the PDIs are the two ARC measures that look at ambulatory sensitive admissions. So if patients attributed to us are admitted to the hospital for asthma when they've been managed through patient care, that's going to hurt the success of our DSRIP program. So we need to put in place the kind of things we need to do to prevent children and adults from being hospitalized for asthma. Next slide. That's the end of asthma. So I think I'll pause again and see if anyone wants to ask a question. No?
Hi, Jesse. It's Avi Silver. How are you?
Hi, Avi. Go ahead.
Someone is attributed to a certain PPS, or they're in our PPS, the Westchester PPS. Is it always going to be in the PPS, depending on if they come out of Medicaid? Are they readjusting, PPS as the years go on? Set for 5 years.
No, attribution changes every month.
Every month.
Yeah.
Track that. Right.
Well, the way I'm looking at it is that crazy. So for other people, I know that Avi is at the Greater Hudson Valley Family Health Center, and I know that the Greater Hudson Valley Family Health Center signed up with both Montefiore and Westchester Medical Center PPS. So that is a more complex situation than someone who only signed up with one PPS. So back to your situation first.
Yeah, we could, okay.
First, I'm going to talk about someone who is in only one PPS. We have certain patients attributed to us And patients attributed to us, probably only some of the Medicaid patients you see are actually attributed to us. And we spent our resources trying to track the patients that are attributed to us, and it's changing every month. We will spend all of our resources trying to track people and of our resources taking care of people. And that's crazy. So we're thinking that if every patient who you see with asthma, you get them an asthma action plan, then the ones that are attributed to us will also have an asthma action plan, and we'll let that take care of itself. I think where someone's only in one PPS, that is, I mean, I just think, you know, we'll do these things for all of your Medicaid patients. If it's the right thing for all of your patients, do it for all of your patients. We'll try and figure out ways to make it easier to do that, and then we'll just let the distribution take care of. So in your situation, so in some ways, I think the same thing applies. I mean, the only difference probably is that we're going to have a three-way negotiation with you and Montefiore about which PS supplies the money for the resources that you need to do that.
Right. Okay. It's a reporting nightmare for you. That's all.
And that's the part that. So in terms of the report part for just in 2 PPSs, we haven't figured that out yet. I just think we haven't figured it out. But I think in terms of what we have to do, we just have to say, let's care of the patients and figure out the part. Because I mean, it is possible. I mean, I know when I was doing a managed care plan, I mean, we had our patients and we sent out stuff about our patients, and we were asking docs to pay attention to our patients. So it's not like I know that you can do that, but I do think that's not the spirit of what we're supposed to be doing. So if we can avoid it, I think we should. So does that? What do you think? Let's go on. But thanks for asking a question, because I hate just talking with no question. So, okay. So the next project I want to talk about was integrating primary care and behavioral health. So this is co-located services at a primary care site. The primary care sites have to achieve patient-centered medical home, level 3. They have to have on-site behavioral health services, regularly scheduled formal meetings around collaborative care within the practice. They have to conduct preventive screenings, and we'll come back when we get to the next slide. They have to have and procedures in place to do a warm, to either connect a patient with services at the time or do a warm transfer to a behavioral health provider if the services aren't available at the time. And there has to be evidence that there is integration of the medical and behavioral health record at that site. Next slide. The requirements that I just read are what's in blue, and then these are the kinds of practitioners that need to participate in this. So for this project, we committed to 22 sites that we estimate will have this number of practitioners at or with related to those sites. But we are happy to do it at more sites. So if there are any practices who want to do integrated behavioral health at a primary care site, we're happy to add additional sites to this project. Next slide. Project, the active patients is, so this is what the state said, the number of patients screened, PHQ-9, and the expert, which is screening for substance use. I today from someone that the state had somewhere said that they've changed it from and to or. Then instead of PH9 and expert, the state has now made it PHQ9 or expert. That is not what it says in the official documents, and so I'd love to see that. But this time, until we see otherwise, we're understanding it to be both. At this time, it is the PHQ9, not the PHQ2. But again, I think there's been some discussion of getting the state to change it to the PHQ2, and then if the 2 is positive, go to the 9. But that's not what it is right now. And this particular measure, we're committed to 2,000 patients screened by the end of June. So obviously that's something to get going. And again, as I said, I'm sure that men are already doing these screenings, but we just need to find a way to do it more systematically and collect the data. Then, let's go back a second. In addition, for the number of other measures that we have to do related to behavioral health, most of these are HEDIS measures. So antidepressant medication management, diabetes monitoring and diabetes screening for people with schizophrenia, cardiovascular monitoring for people with schizophrenia, follow-up care for children prescribed ADHD medicines, follow-up after hospitalization for mental illness, screening clinical depression and follow-up. That one, the screening for clinical depression and follow-up, is not a HEDIS measure, so I'm not so familiar with that measure. Adherence to antipsychotic measures and medicines, and initiation of alcohol and substance abuse treatment. So all of those measures, and most of the, we didn't mark here which ones are called bonus measures or high, I can't remember, the high priority measures. Anyway, a number of these measures, most of these measures are in the high priority category, which means that down the road towards the end of the DSRIP plan, beginning of DSRIP, most of the money is doing those process measures. Towards the end, most of the money comes from doing these measures, and it's going to be important that we particularly pay attention to these and then for the screen for people with schizophrenia, then the actual number of people is quite small. So we just have to pay attention that we get it done for those people, because it's not big numbers. Okay, next slide.
Jessie, before we move on, someone who is listening through their computer but not on the phone line submitted a question. Can you explain acronyms, the P for P and the P for R on the slides?
Oh, yes. So sorry. P for R is pay for reporting, and P for P is pay for performance. Thank you. I really meant to do that, so I really appreciate it. So for reporting is almost freebie, because the state is going to do the reporting of these measures for us. So if it's pay for...
I actually don't think for this one.
That's a chart review measure. Yeah, that's a chart review measure. Okay. So but then Lauren's right. This one's a chart review measure, and so it's going to remind me of my own my old health plan days. You know, we're nurses, just like we did in the health plan, and send them to your office to review the charts and collect that measure. That's how we'll do that one. But the P for P means that we have to hit targets. The state hasn't given us the targets yet, but they're going to tell us the measure and give us a target that we have to hit in order to get paid for that measure. So, I mean, this first, you know, for most of this year, we're going to be paying most of our attention to just sort of getting ourselves organized and finding ways to collect the data. But to the end of this year, and certainly by the beginning of next year, we have to be paying attention to these measures, because the money's not going to continue to flow if we don't. The next slide. This summary of an actively engaged patient for each of the projects. And and the number that I wanted to put here was the number we had to do by June. And that's because, I mean, it officially starts in April, you know, it's getting organized. By June, we have to have collected this many of these things. So it's going to be a real scramble. And I think what we're going to do is we're going to try to identify the biggest practices with the most patients attributed to us, and concentrate on the places where we think we could hit high enough numbers, and just get and sit down with each of you and say, in your office, how can we help you to do some of these screenings and get this done? And I don't know what other PPSs have been saying to people, but my feeling is that I don't think the state is going to have resolved the issues time we have to do this. So I'm thinking these initial screens and initial things that we're counting, we're going to ask you to, as I said, asthma action plan for your asthma patients, screenings for depression, do an A1C test for your patients with diabetes. We're going to ask you to do these things and somewhere keep track that you did that for a patient with a Medicaid patient, that have a record of the name of the patient that you screened, but we were not going to have consent for you to share that information with us yet. So then you'll just send us, I screened 10 Medicaid patients, I did 5 asthma action plans. If you cut me later when you have consent, I can tell you who those people are and show you those screenings, but right now I'm just giving you the number because I think that that project starts before we're going to have consent in place, is my thinking. Any questions? I would has a question about this. I don't know. Next slide. All right. So, does the PPS require from primary care? Well, we need all primary care practices affiliated to achieve patient-centered medical home recognition. We need everyone to get meaningful use certification, which means meaningful use of an electronic record. We have a slide about the details of what that is. We need everyone to connect to the RIO to be able to do information exchange. We need you to be able to share data on the PPS Medicaid beneficiaries. So that's the obvious question and what we were just talking about. We've got to figure out, particularly at the beginning, before we really have the sure sophisticated reporting mechanism in place. We need to figure out some way that we're just going to get some numbers early on. We need to have you participate in our Quality Council and other committees as your interests dictate. And we're all going to need to participate in value-based payment because by the time the DSRIP program ends, that value-based payment is in place. And we will give you support to these things. We'll help with patient-centered medical home. We'll help with meaningful use. We're going to put care managers into primary care clinics. We're going to do hospital transitions with closing the referral loop, et cetera. Now, I just realized we've gone over. Oh, no. No? Oh, no. Oh, no. Good. Oh, right. So, patient medical home. So, I know a lot of you have done patient-centered medical home, and you're going to teach how to help other people when we start talking to you. You probably haven't done it, and it's a big project, and we're going to put a lot of resources into doing patient-centered medical home. Oh, and one thing that I think most of you know, but maybe not, is that in New York, at least at the present time, if you have patient-centered medical home status, if you have level 3 status, you're entitled to $6 per member per month additional payment that comes to the managed care plan, but it's actually a pass-through from the state through the managed care plan to practice patient-centered medical home. I think this is a big lift. It's a lot of work. It's a lot of work for you. It'll be a lot of work for us, but I think it's really going to pay off for better care for patients. And I don't know, I know a lot of you, I can see some of the names on the phone. Who's done it could say something, but once you've done the work, I get the feeling from most people that have done it that really are glad that they've done it, not just for increased reimbursement, but that it really does seem to work better. Would say that's true? Yeah.
Oh, yeah. And I think there's two parts about it. One is that it's really to put yourself through the intense rigor that you would need to demonstrate the capabilities of sort of achieve outstanding care without this process. You could do other things without it, but until you sit down and actually put it on that you've done that, I think that's part of the benefit. It really gives you, it has given us the capabilities and the expertise to be able to go to the next level. For example, base payments or coordinated care or BPCO is really built on the foundation of the mental home. So it's really helped us kind of leverage our experiences to kind of take things to the next level of capability.
So I don't know, were you on the call at the very beginning when I had this, when I was quoting Secretary Burwell and moved to value-based care? I said it, but I'm looking at all the requirements for DSRIP. It's daunting, and one of the things I've just been really thinking is, I mean, we're going to have some resources for people, but we're not cash payments. We're going to have resources. There's the ability of earning incentives, but it seems that the real value is in what you just said. I mean, do you feel that for other practices who haven't started this, I mean, is that really where we're going? Is this really what you have to do to stay in practice? I guess I'm just asking for some, feedback about the whole value of this big list that we're looking at.
Well, this is purely editorial now, so it certainly appears that the message coming from, the government and from Secretary that, the desire is to move all of us to value-based payments over the period of time as outlined, and that's not just this group of patients that we're talking about, and there are many of us on the phone who take care of patients of all different demographics and payers, and really it's where everybody seems to be moving. So that it is a heavy lift, and it is true that I think through DSRIP, you might that we will, as you said, not providing people with cash payments, but providing with the resources that they need to achieve these capabilities. Because don't do this. We have two choices, I think, as healthcare providers. We can continue to do what we're doing and kind of miss the opportunity of getting help with moving towards the ability to have patient-centered medical home status and achieve value. So we sort of ignore that and leave us behind. And then the methodologies that change will leave us behind as well. So it's not just that we're going to all have to be moving towards value-based payments. The core of that is if you don't, the penalties. So from that standpoint, I think that it is the reality that we're in right now in terms of where things are moving. On the other hand, I think it's also aligned with the kind of care that we'd like to provide for our patients. And again, this is my own editorial comment, but providing care that is needed and valued and is cost effective and shows quality. And I think for those of us on the phone, I think we can kind of find that from a professionalism standpoint. So it seems like everything is pointing in that direction, and I think this program through DSRIP will give us an opportunity for all of us to kind of collaborate in the region together to achieve those things.
Great. Well, that's really what I hope. And I had Lauren take out a slide that I kind of now wish I'd left in, but so one of the things that I think that you just said is that I think it's really helpful. I mean, I've been a part of a number of collaboratives, and I really think there's a lot of value in having a place to compare experiences, learn from each other, feel like you're getting some support. And one of the things that we're going to do is we're going to set up a couple of different venues to do that. And I think out of necessity, our quality committee that's going to be across the entire PPS is going to have to meet by webinar, because that's really the only thing that's going to make sense. But I really think it's important to have a place where we can have some face-to-face meetings and just really get to know each other and help each other. And so we are looking at having local development councils that would focus on the things that we have to do around patient-centered medical home, but include the other reporting things that we need to do, so that we can kind of, I mean, I know in some sense every office is different, and we are going to have to do something slightly different in every office, and that's going to be true, and we understand that. But that there's also a lot we can learn from each other, and I think that's going to be some of the real value of this.
Can I ask?
Please.
Hi, my name is Manita Sani. I'm a primary care physician with the St. Southeastern Medical Group. I had a question for the doctor who just spoke, who has this practice going. Can you give us an example of how this medical home, the DSRIP program that you've sort of started, how it helped one particular patient, in your opinion, just to get an idea of how it's really taking place and how it's really made a difference in the patient's life, and also as a provider to be able to help the patient towards the right way. Did that make sense?
Yeah. So, I think part of the foundation of the medical home is to promote team-based care. And I view the competencies of the medical home as developing the ability to take care of our patients when they're not in the office. So a lot of what's built into the medical home sort of and requirements include things like reach to patients with disease-specific conditions that are not well managed or missing opportunities for improving care. We use care managers, and medical homes use somebody like that who's helping to coordinate care when the patients aren't in front of us. So that might be a patient who, and I'm a primary care doctor, so we're busy primary care doctors. And we do have to try to manage everything that we can when the patients are in front of us. But the patient who can go to the emergency room time and again, and you're frustrated with that because you've talked about many. And this is a very simple example. A care manager on the team might be somebody who's outreaching to that patient after a recent ER visit before you've had a chance to see them, and is discussing barriers to access. That might be the reason why that patient has gone to the emergency room. It's something that I think all of us do in primary care if we provided they'd like to, but it's kind of another person on the team who patients identify as part of their primary care team that can help to get the needed care and identify barriers and move them along with their care plan that helps our sickest of the sick patients use the outcomes that we're hoping for them. So that's sort of an example of one way that kind of the medical home structure might do that. I don't know if that's a great example, but if that answers your question. But that's part of that process that we've set up, with our group.
That's nice. Yeah. I had another question regarding the asthma action plan. Now, how would that come about? The primary care doctors have to come down and come up with certain criteria, or is it given to us, or how does that come into play?
What a great question. Thank you. So we're required to, part of the DSRIP project is that we have to come up with an evidence-based protocol for managing asthma. And in fact, it has to align with the state's guidelines for managing asthma. And so one of the things we've done is that all three of the PPSs in the Hudson Valley, so Westchester Medical Center, Montefiore, and Refuah Health Center, agreed that it would be crazy if I came up with one set of guidelines and Montefiore came up with another set of guidelines, that would drive everybody crazy and be foolish. So we have set across PPS DSRIP clinical committee to review guidelines. So we'll set up an asthma committee to inside our PPS to guide this work. And if someone wants to volunteer to, someone really is passionate about asthma care, send me an email because I'm looking for people to put on that committee. So we'll have an asthma committee inside the PPS that will be responsible for this particular project. That committee will take some guidelines, have whatever lines they like or they want to use. It's got to be somewhat based on the state, and go to the regional council, and we'll come to agreement there about what are the basic components that we need to all have in our guidelines, so that every practice has to have they don't have to use the same piece of paper or the same form, but we have to agree that these are the components. And so then we'll come back and we'll say, okay, here's the components that we agreed on. And then we'll have a process where if if someone disagrees with what we came up with, then we're going to have to take it back up through the quality committee until we can get something that everyone sort of thinks is going to work. But the answer is yes, you'll get it, but you have input into what it is.
The deadline for that has to be before June 2015.
Excellent point. Yes. Between now and June 30th, we not have had time to do that process. So now and June 30th, you are going to have to use whatever as an action plan you have been inclined to use. Not time. Right. And then we'll do that process and we'll get lined up. And then I think long term, not even long term. I think one of the stories that meant to me was someone was telling me about a patient mother who showed up in the ER with her kid with asthma, and the ER doc said, "Don't have an asthma action plan," and she opened her purse and took out 5 of them, and she said, "Yes, but I didn't know which one to follow." And so one of the things that I really hope we can accomplish is to get to the point where we have an action plan template that all patients in the region have agreed is appropriate and is posted on the RIO, so that when a patient comes in, and then the RIO has the patient portal, and the patient knows which is the most current plan, and every physician who sees that patient can see what the most current plan is because it's posted on the RIO. So I think by year 3 of this project, that's where we should be with asthma, I hope. Okay. But that's not where we're going to be in April. In April, it's going to be, please find an action plan. The state's got one. You use whatever you want. It's what's your word for it at the beginning.
Okay, so basically that's how you're going to take our word for it too, because there's no sharing of information until that a consent form that's official.
And so when I said take your word for it, so what I think we're going to expect is that it has to be auditable. So it has to be something that later we could come back and say, or the state could say, okay, you said you can the names of the 10 patients and pull through the charts and let me see them. So it's got to be audible. So it's got to be something that you can, you can go backwards and defend it. But yeah, we're just going to have to take your word for it because we're not going to have anything else. And I just want to go back to something that Jonathan said about the care managers. So one of the parts of this project that we really want to do, and I don't know how fast it's going to happen, but one of the projects is to put more management into the system. And my own belief is that where we should put those care managers is in the primary care office. And I really, really want to do that. And there are going to be some resource constraints, and it's going to depend partly on what the attribution is. So I can't say, every primary care doc will have a full-time care manager. That's probably beyond the resources that we're going to have. But within some constraints of the resources that we have and the attribution that we have, we're going to put managers into primary care sites. Yeah.
Before we move on, that dovetails into another question that came in online. What is the status of the PPS and connectivity to the RIOs, and which RIOs are involved, and how is that going to work?
I can answer the second question. RIO is involved. We are very lucky. There is only one RIO in our region. So SYNC, which to be the Hudson Valley region, has merged with the HealthLink New York for the Southern Tier. So the new name of the new RIO is HealthLink New York. That merger just happened this summer. They're just getting off the ground. They're lovely people, and they're really promising some, to be able to do some things that they had not been able to do before. I just saw Susan Stewart today, and she is confident that they are going to be able to deliver on some of the things we need. So the answer to what is the RIO is it's HealthLink New York. what is that? So beyond that, I can't answer any other questions. I mean, who's connected with a survey? I don't know. What are they totally capable of? We're in constant contact. About all I can say. But everyone else knows better than I do. But it is definitely a work in progress, and they are not yet where we need to be.
The takeaway is that they are actively participating with our PPS, and we'll use the capabilities as and when we can, and for connectivity.
Well, thank you. You said that so much better than I did. Yes, we are very actively engaged with them. Yep.
Okay.
Okay, next slide. So I'm not going to read through this slide, but this is requirements for meaningful use. So one of the requirements is that practices do patient-centered medical home. Another one is that they have an electronic health record and that they can meet meaningful use reporting requirements. And the support that we give to practices to help them do patient-centered medical home, we're going to link support for meaningful use right along with the support for patient medical home and do them together. They're related kind of things. And both patient medical home and meaningful use require reports and measures. And I don't know if anyone on the call knows this yet, but I have not yet done the crosswalk between the meaningful use measures, the patient-centered medical home measures, and the DSRIP measures. I'm hoping that there is some overlap so that some measures that we need to do anyway for DSRIP can also count towards meaningful use and also count for patient-centered medical home. But I bet we will be so lucky as to have 100% overlap. So I'm sure it's going to mean some additional measures. I don't know, maybe some of you who've done this know better than I do. Okay, slide and last slide. This is our last slide, and we're just about on time.
We're almost done. Cool. Okay.
So we're at next step. My ask for this call is that we have a survey out, and it's not terribly detailed or terribly technical. We're going to find out how many primary care sites we have, how PCPs are at each site, how primary care doctors are there. We're not trying to get your exact schedule, like you're there Wednesdays from 9 to 11. That doesn't matter. But if you've got full-time doctors, that's different. You've got two people that are each there for half a day. So I'm just trying to get an idea of like the number of FTEs at each site. Because if we're going to do all this support, this patient-centered medical home, the meaningful use, the home, care management, we got to have some idea of how many places we're talking about and how many docs there are. So please, we need that done. And so some of you we've visited to do the survey. Some of you we've called to do the survey. And the last slide is going to be the name. But if you have not heard from us about this survey, please contact us because we can't plan the next steps without that information. Then starting probably in May, maybe the end of April, and in May, from May to September, we'll have a contract with a vendor that does patient-centered home support, and they will come to your practice and do an in-depth survey of your readiness for meaningful use, your readiness for patient-centered medical home, an agonizingly detailed assessment of where things stand so that we can plan the resources that we need to do what we need to do. We'll convene, as I talked about, the local employment teams. We're convening the committees to manage the clinical projects. We're going to convene the quality committee. We're looking for participants for the regional clinical committee. So I know you're all busy, but this project is going to be better in every way and shape, better for you, better for us, better for the state, better for the patients if we get your voice and your input, because you're the ones that are taking care of people, and if we don't listen to you, we're not going to do this very well. So I am totally seeking you to let me know if you're willing to put time in some of this work. slide because I want to make sure we put up. So I'm Jessie Sullivan, and that's my phone number and email. But if we hadn't heard from you about the survey, the people to get in touch with are Melissa Thomas-Belmar or Marcy Colin, and they will be the ones who email the survey to you or call you and fill it out or come and see you and sit down and fill it out. But we really need to get those done. So I have, and we've got a few minutes left. I'll just open up if there are any more questions.
There's one question online if you were including FQHCs in the survey and if you'd reached out to the FQHCs yet.
The answer is yes, and the answer is I thought we had, but if you're at FQHC and you haven't heard from us, please call.
It was not gone.
Right. Yeah, everybody. So. Well, I just want to thank you all very much for your time. Oh, you know, and one thing we didn't figure out a way to, I would love some emails about, is this, so I did this webinar, you know, 5:30 to 6:30 at night, and the next one at 8 to 9 in the morning. I have some feedback of, is that the right way to things? I'm assuming that that works better for people busy seeing patients. But if that's not true, if you'd rather do it a different time or a different way, I would really love feedback about this. So thank you much.
Everyone knows the slides will be posted on the CHRI website. Hello?
Yes.
I have a question. Do you know when there's going to actually be an IT-centric call?
So be IT, a call about what about IT?
Yeah, basically the IT capabilities of the DSRIP project. I mean, for other PPSs, they're IT-focused calls. I wanted to know if this PPS is going to actually have that same kind of methodology and ensuring that we connect, whether it's through the RIOs, or is this going to be the only methodology that we use in order to make ensuring that this particular PPS is successful?
So I know that the Director has been out with a more detailed questionnaire. Our thing was that state has not been entirely explicit yet on some of the questions that we need to, not specifically IT questions, but other things. And we didn't want to ask people really detailed questions and then, like financial questions, and then come back and just have to ask them again when the state clarified what they wanted. And on the IT part, our feeling was that the level of detail that we needed is such that it was just going to be hard to do on the phone or by survey, and that we were going to do it face-to-face between, with those assessments between May and September. But if you have particular ideas about what you want to do already, we're happy to talk to you. So, and the other thing is, I mean, the bills aren't really ready to connect people yet, or so it's a very good answer. But I think like it was just a little bit.
Oh, no problem. That's fair enough.
Hello, Sullivan. This is Jamie Stevens with Middletown Medical. I think I heard a mention of a PMPM for PCMH. Was that specific to this and is that for all 2 or 3 patients that are medical homes?
It is not specific to this program. It is from New York State, so it's not for the PPS. It's just New York State policy. It's only for it's level 2 and 3. It's $4 for level 2 and $6 level 3. It's been in place for several years. You know, I guess there's no guarantee that it's going to continue, but it has been in place for several years, and to my knowledge, there's no plan to start immediately. So that's for any Medicaid patient. I just want to thank everybody again. I really, really appreciate your participation. I am looking forward to seeing you in a face-to-face venue. I like it better when we can see each other. I appreciate your time, and we are looking forward to working with you. And if we haven't surveyed you, please get in touch with us. So thanks. Good night.